from the Netherlands to give the lecture about perioperative guidelines and day case surgery. Why don't professionals do what they have to do?
Good afternoon, everybody. First of all, I'd like to thank the organization for the invitation to present work about the perioperative guidelines. And we heard already a lot about interventions this afternoon and about measures to improve patient safety and quality. But in daily practice, it's not going so easy. And that's what we are going to talk about. Okay. So the content I will discuss with you is about patient unsafety. And in our country, day surgery and surgery in short stay, it's less than 4 nights in a hospital, is normally a part of our care in Holland. It's quite well established. So the guidelines also refer to day surgery and short stay surgery. I'm going to tell you a little bit, just the highlights about those Dutch perioperative guidelines to improve patient safety, and we are going to talk about the barriers and facilitators, how to improve behavior. Perioperative patient safety. Maybe we have a little bit background information about this. In our country, each year, we know from literature and studies, there are about 2,000 preventable deaths in surgery and in care in the hospitals, and more than 30,000 serious injured patients. And the most of them, the biggest part of it, is related to surgery because it's a complicated, complex system with a lot of care providers and communication and so on. And we think that more than 30 to 40% of all of these is preventable. We know, of course, that the high-risk surgery is indeed more high risk to get complications, but also in low risk, they are still happening. If we look to the mortality in the European countries, it varies from 1.2% mortality to over the 20%. And as you can see, elective surgery and day care surgery is most of it elective. It's around 3% in Europe. And the more urgent, or all the people, or complex, it will raise the risk of morbidity and mortality. In our country, it's about 2% overall. And so there are different studies that confirm these numbers. What about the reasons of unsafety? Our medicine has developed enormously, and technical problems are not the biggest part of our problems making unsafety. It's organization, it's human factor, it's communication, and you see that it's around 80% of all the problems that causes the problems of unsafety and mortality in the patients. So what's the solution? And just to go short, is that we have to redesign the process. And good measures to help us is standardization, and something what we didn't like as professionals. And as the standardization, we can use checklists, we can use moments, stop moments, just to see and check from if everything is right and safe to go on, to go further in the process. And ICT will help us, but we can do it without ICT. There are professionals saying that if ICT is not well established in our hospital, it's not possible. But I think that's not true. Then the other part is culture. It has to come off your heart, and we have to work together. It's teamwork, and we must know the problems, and we must know the patient and each other, and we have to communicate well. That's not very easy in surgery, in complex surgery trajectories. So, handovers and checklists, we can standardize them, and we know from literature that it will help us. It reduces mortality by half, and morbidity by 1/3. And then we are talking about big numbers. Only in our country, there are about 1.3 million of surgeries, and worldwide, it's 100 times more than this. We know also that if we have bad communication and bad teamwork, it raises the risk on complications with a factor 5. So, there's a lot of studies that are published yet, and we know this is true, and we are going to use this in our hospitals. But it's not very easy to find the solutions one-to-one of the measures that we do, that we take, and real improvement of care. So, the Dutch Inspectorate, Healthcare Inspectorate, did 3 analyses of the Dutch hospitals. And to go short, they told us that we did bad work with respect to multidisciplinary and standardized management of our work. Bad communication, and the patient was not centered really, and also administration and documentation should be improved. So they ordered all the hospitals and professionals in our country to improve this and to make agreements and guidelines about this. So that's why I got involved as president of the working groups of our national guidelines, and all the relevant professional organizations, scientific organizations were involved, all types of surgeons, anesthesiologists, the hospital organizations, patient organizations, and so on. So we worked for 6 years in 3 parts, in pre-operative, intraoperative, and post-operative guidelines, and the last guideline is going to be published this month. It's about communication, so we made agreements about the minimum standard for communication and teamwork. And we use standard checklists. And I'm going to show you that there are several stop moments that are obligatory in the whole process that professionals have to use to use those checklists and checks. Also, the handovers have to be standardized because we are going to forget something. And in this trajectory, it's also transparent who is going to be responsible for what action in what phase of the whole procedure. And we are talking about indication for surgery until dismission from hospital. This also makes it possible for a track and trace function of the patient. So where is the patient in his or her procedure or her process? If there is complexity, we should use a case monitor, a nurse or a doctor or another professional who has to communicate and who has to monitor everything is happening with the patient and to arrange that everything is going to happen in time. And there were a lot of problems with equipment, medical equipment. Everybody for years used equipment not really standardized or managed by the hospital management. Hygiene is also a big issue, behavior like hand washing. And medication, as we all know, is medication one of the topics that there are many mistakes made in all hospitals on all departments. This is just a part of the whole perioperative trajectory. As a primary care doctor refers a patient to the hospital, to a surgeon, then the surgeon must have a minimal checklist before he can send the patient to the anesthesiologist for preoperative screening or assessment and optimization. And also the anesthesiologist must check, and there must be agreement from the patient, surgeon, and anesthesiologist before we can further. And so on. There are several phases defined, and every phase is finalized by a stop moment, which has to be done in all hospitals. So the next one is preparation in the hospital when the patient is admitted, and before the patient leaves to the operation ward, then there must be checks about changes in condition, antibiotics, and so on, all measures that had to be taken, whether they are really taken or not. There's of course a check when the patient arrives at the operating theater. There's timeout with wrong side operation of surgery, like in time or timely antibiotics, and so on. And so also at the end of the operation, a sign out, going to the recovery room, from the recovery room to the department, the ward, and finally, when the patient is going to be dismissed at home, there are also minimal checks which have to be done. The guidelines provide a whole description of all activities and phases that must be recognized in all hospitals, because we know that for more than 90% is the same in all hospitals. And so we provided a system that there must be a final responsible in each hospital, and it is probably the same one in all hospitals, a surgeon in the same parts of the procedures. But for the operational activities, you can choose in your hospital, because things may differ, so there is some room for local organization in it. And also here you see the green line. This is one of a stop moment after the end of a certain phase. This is, by example, a stop moment. Can the patient be planned for surgery safety? And there are certain items in the preparation that must be checked. Perioperative details like, do we need radiology? What kind of antibiotics? And do we need an intensive care bed for post-operative care, and so on. Another one is before the patient is going to be transported to the operating theater. And also here, like I told before, there's a minimal checklist that have to be checked by the nurse and by the doctor of the ward. But the surgeon is responsible finally for this phase. We also provided with the guidelines indicators for internal benchmarking and external benchmarking for society, but also for Dutch inspectorate, and to improve yourself. So we have all the stop moments. We call it a bundle, and you can score for the whole bundle, but if you are implementing, of course, it's not very reasonably that you have 100% in the beginning, so we use the stop moments apart. But there is timely antibiotics given to the patient, agreement or a protocol about anticoagulants. There are a lot of problems in the hospitals between anesthesiologists, cardiologists, surgeons about the arrangement of antibiotics, so we have to use a protocol for it. Another one is the responsibilities about medical equipment, and we have to do prospective risk analysis of medical equipment in all hospitals. We have OR rules, behavior, golden rules, and we must learn to speak up to each other if one is not demonstrating the right behavior. It's not always easy. So we have to train about this. And there's other outcome measures like post-operative wound infections and complication and mortality registration. And that's we are going to compare also in our hospital. So, the prophylactic treatment like beta blockers and antibiotics, we know there are guidelines, but they are not used often. So that is a problem of the professional behavior. And from literature, we have knowledge about the barriers that we can identify. We have from the Dutch inspectorate, and we did a pilot study, and now we are doing a big study, but that's not the material I'm going to present. We can divide the barriers and facilitators at the individual or professional level, healthcare team level, the level of the patient, healthcare organization, and the wider environment, like society. I'm only going to present you the highlights. Like for the individual level, clinical guidelines leave too little room for taking into account my own considerations. It's autonomy, professional autonomy. So we have to learn other behavior for cooperation. Expected changes in organization for the process. Professionals don't like to change because we are good in things doing quite long the same. Safety checks interfere with my daily traditional process. It's the same problem. Expected workload. If we have to change, we always think there's going to be a lot of work. And there will be in the beginning, but afterwards it's going to be better. We know it from the studies. The lack of available evidence on positive effects on the introduction of the guideline. If there are guidelines, we are not using them fully, and if they are not, we say, is there evidence? So this is also a part of our behavior as professionals. Then we are all educated for the content, as a surgeon, or as an anesthesiologist, or another kind of medical doctor. And we are not educated with organization and interest in perioperative care, so it's a problem for most of us. The societies for surgery and anesthesiology are the owners of the guidelines, so they are aware of going to update the guidelines in the future. And there is commitment about the members of many relevant associations, as I told you before. And the healthcare problem of perioperative unsafety is enormous, challenging all professionals involved. There's a lot of interest and attention at this moment in the media, in government, and so every day we read something about our newspaper. A problem is that if you learn something and you're young and you're going to work between your older peers, then they tell you, stop it, we don't like this, we don't work like this. It's very difficult for you as a young professional to change your behavior. And facing the problems with multidisciplinary cooperation within the operative chain is also very difficult because we don't see each other working. It's a virtual cooperation, so we have to find something about this. What is going to help is like training, crew resource management or crisis resource management. There's team steps developed in the United States and things like a briefing, debriefing in the beginning of the operating surgery program and the end of the day. Then we can talk. How did we do well? What were the problems and what can we learn? The lack of facilities. So there's no money or there's no ICT or there's a lack of surgeons because it's going to take too much time and so on. So one of the problems is that in our system the production of care is financed and not the quality, not the safety. So this is a problem. This does not help us to change our behavior. And at system levels, we have already two big studies with 10 enthusiastic hospitals contributing. We have a system that we are helping hospitals to improve, so they have to find out themselves how to work. And we have the legal status of the guidelines that will help them. And Inspectorate is checking all hospitals. So, at this moment we have a big study in Holland with a multi-center study with tailored interventions, and we try to show that if we are going to use tailored interventions, then that's better than the normal intervention, the natural intervention, because then only 10% of the compliance is going to be reached, we know from literature. And for us it means that minimally more than 300,000 adverse events should be prevented. And the potential reduction, if you only reduce it to 1/3 of it, is more than 100,000 serious adverse events. Ladies and gentlemen, I'm coming to the end. We know that standardization teamwork, like in aviation, makes it more safe. And it's a factor 1,000 that aviation at this moment is more safe to fly as also like a patient or to be operated in a hospital. And the last thing I want to give you as a take-home message is from Avidus Donadedian. He was he comes from Lebanon and went to the United States. He was one of the first professors in public health, and he said, ultimately, the secret of quality is love. You have to love your patient. You have to love your profession. You have to love your God. If you have love, you can then work backwards to monitor and improve quality. Thank you very much.